I'm happy to be here. Many thanks for hospitality and friendship. And as it is late, I have just chosen 3 points. What is new? There is a new epidemic, and we've heard of them by Monica Avgelovsky, of non-alcoholic fatty liver disease that leads to an increase in global burden of disease. But it's also alcohol consumption that has to be taken very seriously as a cofactor here. We have heard about that from Helmut Seitz. And as the day dawns, we've heard from Robert Timmer also the stages that liver diseases, if not recognized and treated, do go to hepatocellular carcinoma. There are 2 guidelines, one from the AACD and one from the EASL, and there are new systematic therapies. And finally, in 2018, we are beyond sorafenib, and there are 2 options, molecular targeted therapy and immune therapy, and there is a speed up in medical therapy of hepatocellular carcinoma. The prevalence, it's not the heart, it's the liver that affects most people worldwide, and this relates also to mortality. And this is clear that that's our task and that of global health managers, that we have to identify these patients and that we have to ensure for adequate screening and surveillance programs, because that is what liver diseases do. They lead to liver cancer, and you see that already the second cause of death worldwide in male patients. And in a few years, we will discuss liver cancer globally, like breast, colon, prostate, or lung cancer. So that is very, very alarming, because the incidence of HCC is increasing worldwide, despite of the decreasing incidence of other solid tumors. And what you can see here is that there is an increase up to 75%, and that is here developed countries. And why does this happen? People get older, there's more population, there is dependent on certain birth decades HCV, we know that, but there is also a new NAFLD epidemics, and Monica Avgelovsky reported for that. And you see here that this will continue. And so we have clearly defined risk factors, and this is why this tumor is a tumor that calls for screening and surveillance. And screening and surveillance is cost-effective and saves lives. It's important to know the risk factors, and it's also important to know that 90% of the HCCs develop in cirrhotic livers, but there is also direct carcinogenic action by hepatitis B virus, aflatoxin, and also NASH. So these risk factors, they can go directly from normal liver to hepatocellular carcinoma. That is important in our research because we have to recognize a metabolic syndrome and the corresponding CT and MRI images, and when a nodule occurs, think of hepatocellular carcinoma. This is also very important in designing adequate survival and surveillance strategies, and the comorbidity has already been touched on. New guidelines. The AACD is just 1 year old, and they have chosen a very practical approach, and they have asked 10 key questions relevant for the management of patients with liver disease. And the chair of the session, Peter Galle, has also been the chair of the new EASL guidelines, and this is a very elaborate guidelines that he will comment on, and you see that every available evidence, including new systemic therapies, has already been included in this guideline. So let me comment on the AACD guidelines and set the stage for Peter and the talks to come, because these are the questions that are relevant in the clinic. So should adults with cirrhosis undergo surveillance for HCC? Which test? Of course, they should undergo surveillance. AACD suggests ultrasound with or without AFP, but only these group of patients. And you hear later on that the EASL takes into account high-risk fibrosis patients and high-risk hepatitis B patients. I think that's important given the facts that we know from carcinogenesis. Should adults with cirrhosis and suspected HCC, which imaging technique should we choose? Contrast-enhanced ultrasounds, we will have a talk on that. Multiphasic computing, CT or MRI. And Well, the ASLD says so you can do general recommendation because the performance of CT and MRI is similar. That's true for tumors that are larger in size than 1 centimeter, because you have to remember that sensitivity depends on tumor size. And clearly, the MRI is more sensitive for tumors that are below 1 centimeter, and that is to be kept in mind. And there's not much use of contrast-enhanced ultrasound in the US, and I'm therefore very happy that the EASL guideline put a special emphasis on ultrasound and on contrast-enhanced ultrasound. Should adults with cirrhosis and an indeterminate hepatic nodule, so we have done surveillance with ultrasound, there is an indeterminate nodule, and the AACD says that is a lesion that does not fulfill the non-invasive criteria. It has not the typical contrast behavior, or smaller than 1 centimeter. What should be done with these nodules? And the AICD says you cannot recommend one option over the other. You'll see that the EASL chose to propose a way of working up of these patients, and the ASLD suggests against routine biopsy of these nodules. Biopsy has another focus in the EASL guidelines. And when you think about these questions, these are long-standing controversies in HCC management and treatment. And we have to take them into account because we have to deal with 2 million people worldwide. Should adults with type 2 class A cirrhosis and early stage HCC, T1, T2, be treated with resection or local regional therapy? And I have to use that from the EASL guidelines because just to give you background behind all the questions that relate to therapy. And the BCLC system is absolutely recognized because coming from the Barcelona clinic, it takes into account the liver cirrhosis, the tumor, the patient, the prognosis, and the treatment. So it's all in one. And there's 3 options for curative treatment: local ablation, resection, transplantation. For intermediate patients, it's transanterior chemoembolization, and for advanced stages, systemic therapies. In the AASLD suggestions, there is a clear commitment for resection over local regional therapy. And I'm very happy that the EASL guidelines comment on that. They also focus more on resection, but comment on radio frequency ablation as an alternative option. And I do very much appreciate that because you know that the most difficult decision is which of the curative treatments to offer. That afflicts many decisions, surgical, transplant decisions, and comorbidities of the patients. Should adults with cirrhosis and HCC that has been resected or ablated successfully undergo adjuvant therapy? That is a real challenge, and we've seen that no substance can prevent recurrence and at the same time reduce the carcinogenic potential of the liver. So this is why both AASLD and EASL do not recommend adjuvant therapy. Should adults with cirrhosis awaiting liver transplantation and HCC T1 be treated or undergo observation? That's a difficult question because it reflects the allocation policies and the legal framework in the different countries. But the AASLD suggests follow-up imaging over treatment for patients with cirrhosis awaiting liver transplantation who do develop T1 HCC because the dropout is only 4.5% by 6 months. The dropout for patients fulfilling the Milan criteria, so it's 1 tumor not up to 5 till 3 nodules up to 3 centimeters. The dropout rate for these patients is much higher, it's 25%. So this is why AASLD and EASL clearly say in these patients we need a bridging on the list to liver transplantation. And while the AASLD does not recommend one option over the other, there is a clear statement from the EASL. You will hear that later on. So we need bridging in patients fulfilling the Milan criteria on the waiting list. Should adults with cirrhosis awaiting liver transplantation and HCC beyond criteria undergo transplantation after being downstage to within Milan criteria. So both EASL and AACD say, okay, downstaging is feasible. If it's successful, this patient can be transplanted. In Germany, they do not get any standard exception priority on the waiting list. So you can do it, and probably these patients have, because we know these patients have a good biological response, but the legal framework makes it difficult. So you may think of living donor transplantation in these cases. Should adults with cirrhosis who are not candidates for resections or transplantation and who are beyond Milan, should they be treated with TACE, with transarterial radioembolization or external radiation? There is no commitment for the AACD, only a commitment for treatment for the intermediate stage, but there is no preference, and the EASL clearly votes for TACE in this subset of patients. Should adults with type 2 class AB and advanced HCC with macrovascular invasion or metastatic disease be treated with systemic or local regional therapies or no therapy? And the AACD recommends the use of systemic therapy. And this is where we come to the third point of my talk, new systemic therapy. So that's the initial sharp study. Remember this, that was 10 years ago, survival 10.7 months. Multikinase inhibitor inhibits angiogenesis, proliferation, it leads to apoptosis, and really fueled the look into new multikinase inhibitors. But then we had a series of RCTs that failed. And we couldn't really speed up cancer drug development for a long time. But then in 2017, with the regorafenib, there was a benefit in second-line therapy, and that was the first sign of hope for patients with hepatocellular carcinoma beyond sorafenib. So that is approved for second-line therapy of hepatocellular carcinoma. And that was something that was really benefit for our patient. And this is something new, that's lenvatinib, and this is lenvatinib in first line, and don't be confused, this is a non-inferior trial. And you see in first line, lenvatinib really can compare with sorafenib and maybe an alternative option. This is cabozantinib, also multikinase inhibitor. The targets are here. And second line, you see here a clear survival benefit. And this is another field that we are entering, immunotherapy, blocking immunological checkpoints, using the immune system to attack the tumor, and not only concentrated into the hepatocyte and its pathways. And that is the second line nivolumab. It's an anti-PD-1 antibody. And you see here that the survival was 15.6 months in patients that were sorafenib experienced. And that led to FDA approval because there was a new hope for patients with hepatocellular carcinoma. This is ongoing. This is first-line nivolumab in sorafenib naive patients. So immunotherapy as a new baseline of systemic therapy in HCC. This is pembrolizumab, and pembrolizumab was a drug, and the first drug that the FDA approved in several solid tumors. And the only criterion was high microsatellite instability. So the drug was not approved for specific cancers, for specific tissue. It was approved for blocking or activating a pathway. And this is maybe the future of cancer therapy and also of therapy for HCC. This is a very simplified slide. And I just like to show you that we are beyond sorafenib. These are the substances, only substances that have already proven that they are working and that they are our new medical therapies for HCC. Please forgive me that it's a simplification. You shouldn't do that according to Einstein, but I just wanted to have you remember the names that will in future determine HCC therapy. This is a beautiful work that was published in Cell, and that's what I said, the future of molecular targeted therapies. We see a different etiologies, we see a new omics method for characterization of these patients and for identifying the essential pathways. That will be the future for precision medicine, and this will be helped or edited by a new generation of cancer immunotherapies that use the patient's own immune system to kill the cancer cells. And with that, I thank you for your attention. This is Regensburg, and I'm happy to take your questions.